Today we're going to do breast augmentation with fat transfer. The patient is on the table ready to go. I think it's a great alternative for someone who is looking for a moderate size increase, all natural. There are several advantages to the fat transfer. There's no need for implants, so you don't have to worry about the implants. There's no implant palpability, ripples. It feels and looks like a natural breast. We have a beautiful petite patient in the excellent shape today, and she's just looking for breast enhancement, just slight enlargement. She's going to be okay with just maybe a cup size, maybe even a half cup size. So we elect to use your own fat to augment the breast. So there's no need for breast implant, there's no need for maintenance surgery. It feels natural, that's your own tissue. So whatever fat is going to survive, which is about 50 to 60%, it's going to behave like your own fat. You gain weight, you're going to gain weight in that area. You lose weight, that fat is going to shrink. Ticklish, huh? It works out. What do you do for working out?
Everything.
Everything. I can tell.
Yeah.
I can tell. I think this is going to be where kind of the money is right here. We're going to kind of shorten your buttock a little bit and take this. No, we're gonna leave the butt. We're just gonna work.
If we can.
Let's see on your inner thighs. So those are usually my go-to donor side. Lower back, lower abdomen, and inner thighs. But it all depends. If you have stubborn fat deposits and you want to use them for a little breast augmentation, then we can work with anything. She already has a beautiful waist as it is, and I accentuate that a little bit. Good. Let's look in the mirror together. Okay. Let's see what we mark there. Not so much here, but in the back there, like this stuff.
Yeah, good.
Okay,
yeah.
So that's good stuff. She has a beautiful breast shape, and contrary to popular belief, you cannot change the shape that much with the fat because it has a consistency of an applesauce. So you can improve the fullness in the upper pole and the cleavage area, but if you have a little bit of a droop, usually it doesn't change it by much because the fat just takes the shape of already existing breast. And the good news that even for breast augmentation, the incision is usually small, about 4.5–5 centimeters, but here it's just going to be a little poke, which is not going to be really noticeable right in the crease there. So this is a win-win. No bridges burned. If it's not enough, we can always use implants, but a lot of girls now opt out from the implants. Good.
Okay.
All right. Well, I'm excited for it. It's going to be good. So the first step of the procedure is to get the patient all numbed up, nice and comfortable. So we're using Tumescent analgesia, which is a fancy name for a mixture of lidocaine, adrenaline, epinephrine that shrinks the vessels, and I also add tranexamic acid, or TXA, to help to reduce the amount of bruising and bleeding afterward. So I'm using this metal hollow straw that goes under the skin through a tiny little poke. So we made little pokes after local anesthetic, and we're just injecting that fluid under the skin into that space, subcutaneous space, or under the skin space where the fat is located. So this will allow us to extract the fat without any pain or discomfort and without any blood loss. And this is kind of the worst part, to be honest with you. This burns a little bit, patients feel a little tightness, but not bad. Our patient is breathing some laughing gas, and it helps quite a bit. She's doing good. How are you doing there? Good, she's doing good. And you can see how this side is now nice and tight and it turned pale because that epinephrine, and will feel cooler to touch as well. That epinephrine or adrenaline kind of kicks in. We are done with the numbing part. The patient is all numbed up. She's awake. She's doing great. She did good. And we're going to get the fun part. We're going to get to the fat harvest, addressing some of those stubborn fat areas, which she doesn't have a lot. It's mostly to harvest the fat for fat transfer part. We prep the patient. I want to make sure our fat is all sterile. Multiple options and different cannulas for different areas, for different purposes. The difference is in the number of ports, how are they designed, if the suction is all around versus the suction is only on one side to protect the skin. Like this one, for example, like there's no ports or openings on the upper surface, but they're all on the bottom. So this is to suction deeper fat. And this one is all 360. This is the most versatile cannula, flared Mercedes, because it does look like a Mercedes sign. So it's attached to a special power handle that vibrates. And very rapidly helps to extract fat in a more efficient manner and to create more even result, and just reduces the surgeon's fatigue, because in old days we just used to do it all manually. So I think this is a good advantage to use this. And this is going to go into our sterile container here, sterile canister. So the fat is going to come out from the patient into the canister, and then when we're ready to transfer, we're just going to dump the fluid because the fat is going to separate. It will flow to the top, and that tumescent solution is going to be on the bottom. We're going to remove that, and we're going to re-inject the fat. So it goes into the canister and from the canister back into the patient without seeing the outside world. So now we're doing the fat extraction. You can see nice, fluffy, yellow, healthy fat. Looks like an egg yolk. This is going to be great fat for a fat transfer. You can see it's going into the canister. You can see there's very little blood in that fat. That's because of that epinephrine. Especially people trying to lose weight, they say it's very motivating to see the fat that was taken out. So next time you want to eat that cookie, you're going to look at the photo of your fat to motivate. I always tell patients it's not natural for a female, even the fittest ones, to have six-pack. It's okay to have a little bit nice little belly there. It's healthy looking, you know. We are done with the patient's front. We completed her stomach, inner thighs. Now we are in the back area, one little poke. And you can see even in the skinnier patients, usually we're able to find good amount of adipose tissue. So a liter of lipoaspirate, out of that probably half of it is the fat that we will be able to utilize. So that makes it 250 cc's per breast. And we're not done yet. So usually we're able to find decent amount of fat even on patients with the low fat content relatively. So I'll just keep going here. So we got 1600 cc's of lipoaspirate. And we're just giving it a little bit of time to separate. I re-prepped the patient, I cleaned up the skin. We want everything to be super sterile. I'm going to change my gloves before the fat transfer. You can see the fat separated here in the canister. And on the bottom, this is a tumescent solution, that solution that we put in, mixed with a little bit of blood. That's why it has that reddish color. It's not blood. And then the fat with a little bit of oil that came out from destroyed fat cells floats on the top. We're going to dump the fluid because we don't want to occupy the space with the fluid. It's going to go away and there will be no result. So we're going to get rid of the fluid and we'll utilize the fat for the actual fat transfer. So we're getting rid of the fluid and we're leaving only the dry squeeze, the important part, the fat. We don't need the fluid, we need all the fat. And then I make a judgment based on how much I have. Obviously it has to be somewhat symmetrical, so you want to use same amount of fat on each side unless the patient has an underlying significant asymmetry or unevenness. And then we try to compensate for that a little bit. Last step, we're going to add some antibiotic just to prevent any infection or anything like that. For injection, I'm going to use similar cannula I used for suctioning. The flared curved Mercedes. It allows me to stay away from the chest wall, not to injure the underlying muscle, protect the chest wall. Obviously, we don't want to go between the ribs accidentally, which is extremely unlikely, but we want to keep everything safe. And I'm going to inject with that cannula using the same power-assisted tool. Marla, can you dial it up a little bit so we can prime it faster? I'm going to prime the system, get rid of all the air, and we will be able to see fat coming out at the end of the tube. I'm getting rid of all that extra fluid. Now I start seeing fat particles coming out. Okay, now Renee, give me a good shake of that canister. Mix it up so see that there's a little bit of pocket of fluid there. Yeah, more. So Renee is just kind of mixing it up so it's all homogeneous fat. And now we'll look how much we have total in there. So we have 900 of pure fat. So that's, we can use 400, 450 per side, which is a good amount. Remember, about half or maybe 50% of that, sometimes 60% will stay. So I'm injecting in multiple different planes. That fat is being deposited between the healthy breast tissue and it will lace. Because for that fat to survive, it has to ingrow with the surrounding tissues. And I tried to inject using what's called retrograde technique. When you pull out, this is safer. So I don't force the fat in, I just lay it as I take out my cannula. And you can see the right breast is already getting bigger. And I constantly change planes. I deposit it in multiple different planes. And the breast will be bruised, will be swollen after this. So sometimes I tell my patients don't get too excited because they see how large and engorged this breast is. This is not what they're going to get at the end. The swelling is going to go down, the body will absorb all that fluid, and not all of that fat will survive. So Renee, my assistant, she tells me how much we've already put in, so we keep track. How are you doing? If I have very limited amount of fat, I would usually try to target the cleavage area and the upper pole, the fullness and up top, because that's where usually majority of the females want the fullness to be. So I like to have fullness up top. Right, it's getting tighter. Well, because it is getting tighter. We add in the volume, so it's normal to feel some tightness. The common question people ask, how much can you put in? And it all depends on the skin tension, kind of up to my judgment at the end, because when it gets very tight and it's dense like a drum, that's the time to back off, because that pressure within the breast is going to be so high that the fat is not going to survive. So we want to make sure we make a difference there, but at the same time we want to make sure all that fat is going to survive. We're not just stuffing that extra fat in there which is not going to survive. And you can see this is the left, this is the right. I think this is quite a difference there. So I'm going to start doing the same thing. I'm just trying to mold that fat a little bit. We're on the other side now. We will match it with the other breast. This patient had very symmetrical, nice, beautiful shaped breasts, so we just need to enhance them to fill them up a little bit. If someone has a significant discrepancy or there is a difference, unevenness, we can try to compensate for that by putting a little extra fat on one side. Again, retrograde technique. The fat is injected when I pull out the kidney. You just place in it, lay in it. So it deposits some right above the muscle. Usually I don't do injection directly into the muscle because it hurts if the patient is awake. There is no reason. So it's mostly in the subcutaneous space and some among the breast tissue. And as the breast gets older, majority of it becomes mostly fat tissue. So the older we are, the more fat we have in the breast and the less actual breast tissue.